this drug is dangerous. You cannot play with it. It's not funny. It's not something to laugh about. And trying to send that message with clarity that good people don't smoke marijuana.
Every day, every night, all the time. Every day I need an ounce and a half. SP, the only flow that you know, with a bounce and a half. Listen, kid, I need a mountain to cast so I can roll up, hop in the whip and like bounce to the ab. I get high cause I'm in the hood, the guns is around. To take a blunt just to ease the pain and humble me now.
Greetings. Did you know that cannabis is the most commonly utilized federally illegal drug? A recent study showed that over 50 million individuals admitted to having utilized cannabis once. And yet, it is a Schedule I drug on the Controlled Substance Act, deemed as having no medicinal use and a high potential for abuse. In this series of interviews, I speak with experts within the cannabis space. We discuss everything from the public health and the medical concerns to environmental challenges and calls for social justice. There's much to discuss, but even more to learn. Join me on this journey into the emerging cannabis industry. Good afternoon. I am Dr. Tyson-Lord Gray, and we are here again for another episode talking about cannabis research, specifically today thinking about public health and the science around cannabis and the emerging cannabis industry. And I'm super excited because I'm getting to talk to a true expert in the field, Dr. Jeff Chen, who is the founder of Radical Science, which is an organization that does research in cannabis and the impacts of cannabis on health. But also the former founder and executive director of the UCLA Cannabis Research Initiative. So a lot of expertise and experience in this area, and I'm super excited to have him here. He's also an MD, MBA, so as a dual degree holder myself, it's always great to talk to someone else who's a glutton for punishment. So just well-rounded and truly an expert in this field. And so just to start off, Dr. Chen, if you could share with us what got you into this area of cannabis. I mean, you have an MBA, you have an MD, you could do a plethora of things, and you've chosen to situate your research here in this space with cannabis. Tell us about that interest and just kind of what brought you to this particular field.
Sure. Well, first off, thanks, Dr. Ray, for having me. It's a pleasure to be here, and it's such a fascinating field to talk about. So I'm really excited about all the things we're about to dig into. My personal story and journey here goes back to when I was, little kid. I wanted to be a doctor. I thought health was this very important thing, and I wanted to play a role in making a big impact. And so I knew I wanted to be a doctor, but I also knew I wanted to work at a systems level. How do I create large-scale change? And so, I was pre-med studying at Cornell, also in New York, but also I was taking business and econ and entrepreneurship classes. And then when I was getting my medical degree at UCLA and also getting my MBA at UCLA. And I thought I was going to go run a hospital or run like an insurance company, and that's how I was going to I was going to fix healthcare. And I don't want to jade the audience, but healthcare is broken in many, 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 many different ways. So I said, okay, I could spend my whole life working on this and maybe make incremental improvement. There's so many things out of my control.
Yeah.
The federal regulations, the state regulations, what the insurers want, what the doctors, all these things. And I started looking around towards the end of grad school, and I started looking at non-prescription health interventions. These are things like supplements. These are things like cannabis. This is aromatherapy. This is even food as medicine. And I said, wow, isn't that fascinating? You could release a product without needing to go through 10 years and $1 billion of FDA approval.
Yeah.
And if I'm as a consumer and I believe in the product or I'm interested in trying it, I hop on Amazon and it shows up. In the case of cannabis, I got to go to a dispensary. But that's a fundamental disintermediation of all these stakeholders that previously sat in the healthcare value chain. The FDA, doctors, universities, pharmacies to get the meds, insurance carriers to reimburse. And so I looked around and identified cannabis as the most commonly used non-prescription health product in America with the least amount of data. And it shocked me that when I was looking at the time, and it was there was 50 million Americans using CBD or cannabis or other cannabinoids such as THC. 50 million. Not a single product was FDA approved. Not a single one had been through any clinical trial. Doctors weren't trained about this in medical school. Hospitals weren't allowed to allow these products onto their property. Insurance didn't reimburse for it. Pharma wasn't involved.
Yep.
Yet, 50 million Americans were going out there getting the stuff. So the cat was out of the bag. Now we needed to go and gather data and science and figure out what the hell was going on.
Right.
And if we could do this for cannabis, figure out the good and the bad, well, why couldn't we apply a similar lens to all the other things that could be awesome health interventions? We just need to know who shouldn't use it, who should use it.
Right.
Whether it's aromatherapy or getting food as medicine, supplements, functional mushrooms, all these things. So after graduate school, I did what very, very few young, recently graduated doctors do. I did not do residency, so I have no practical experience.
Oh, wow. Okay.
Pretty useless in that arena. And I was very fortunate to get a little bit of seed funding from UCLA and started the Cannabis Research Initiative. And was there for 3 years running and growing the program. And it was exciting. We were doing some of history's first ever work in this area, and there were dozens of faculty involved. And it was a very exciting time. And I'm sure throughout this interview, we'll dive into deeper into the barriers to research, what we know now, what we don't know. But one thing that became very apparent throughout these 3 years was that, to no fault of UCLA, but because institutions like UCLA take federal funding, they're beholden to all these sets of regulations that just don't make sense. For example, and I'm sure we'll dive into this deeper, we couldn't study literally a single one of the cannabinoid products that 50 million Americans were using.
Oh, wow.
We couldn't even allow it onto our campus. We had to go order cannabis that the DEA grew in Mississippi and would basically mail you in freeze-dried, exactly.
Oh, wow.
It's very bonkers.
And this is even here in California.
Even here in California, correct. Because UCLA took federal funding, they followed federal law.
That's true, yeah.
And in addition...
That's the complicated legal landscape where it's legal in the state, but then it's still legal federally.
That's exactly it. Yeah. And for many other reasons, clinical trials, health research in general is like stuck in a very old model thinking. And to no fault of anybody, it's just how the process works. When you're spending $1 billion in 10 years to get a drug FDA approved, the system goes at a very slow pace running studies. So after about 3 years at UCLA, I realized there were ways that this could be done, but it couldn't be done at a university. There were better ways to do this. You needed to get rid of federal funding. You needed to go virtual, get rid of physical infrastructure. So that was the impetus as to why I left and started Radical Science. And our mission is to basically democratize access to clinical trials, so that non-prescription health products, for the first time ever, can go through validation. And we can start to understand, what do they do, what do they not do? What are the benefits, what are the risks?
Interesting. Okay.
And what's beautiful is if you take these non-prescription health products and you layer in lots and lots and lots of rigorous data, you turn them into precision democratized solutions for human health.
Yeah.
And so that's what I work on now. Our main focus right now is still cannabis and cannabinoids, because that's what the public needs. But eventually we're studying everything under the sun that a doctor doesn't prescribe you, basically.
Got you. So now that sounds like a heavy lift. And specifically, I guess I'm interested in, what does that process look like? So specifically with Radical Science, obviously there's a lot that you would have been limited from doing at UCLA because of the structure with federal government. And so because we know that cannabis is a substance 1 drug on the controlled substance list, which technically says it has no medicinal benefit, right? Which is interesting when you have 36, 37 states now, I think, that have legalized medicinal marijuana. But yet, based on the federal government, it has no medicinal use. I think it's actually worse than cocaine, right? Cocaine is substance 2. Marijuana is substance 1.
Right, yeah.
Along with heroin, LSD, right? And so even when you step outside of the academic university, when you step outside of the federal funding, how much flexibility do you have to actually study this drug? Are you able to do like any type of human trial test, right?
Great question.
Like so much that I think would be significant in terms of what are the products, what's in the products,
Yep.
how are individuals then impacted and affected by those products, which requires human trials. And I'm just thinking from a research perspective, right? Like, how do you even get clearance for that for a drug that is technically illegal?
Yeah. Well, that's why it's awesome when you detach from any sort of federal funding and you have, private investors and you have a business model and stuff. But maybe the setup here is to explain further the classification of cannabis. What are the barriers right now that researchers and universities face? And then, I don't want to focus so much on radical, but I can talk about how we're kind of solving some of those barriers. But it highlights the issues that cannabis has faced.
Okay.
So, briefly in terms of, having no medicinal use, right? So cannabis used for thousands of years, documented as early as the Chinese, 2,000 to 3,000 years ago. They actually called it the big numbness plant because they recognized it had pain relieving effects. Romans, Greeks, Egyptians all used it, the Persians, Napoleonic France, all these things. And even in America, up until about, within the last century, it was actually listed as an official, it was listed in the US Pharmacopoeia as a recognized medicine. Mm-hmm. Doctors could prescribe cannabis. You could walk up to a bodega in New York and buy some cannabis. All of this really started to change, and that's probably one of your separate lectures, so I won't focus too much on that. But the biggest shift came right around 1970. During the Nixon administration, it became a Schedule I drug, and that basically defined it as having no medical use and a high potential for abuse. And it stayed that way for half a century. Now, what is unfortunate about Schedule I drugs is if I'm a researcher wanting to study it, I need special licenses to get. I need to get special clearance. I've jumped through all these hoops, background checks. I need a safe, of certain specification that no one can bust through to store the Schedule I drug. I need security systems. I need cameras. I need fingerprint locks. All these extra hoops. So research in general is already slow. It's already expensive. It's already difficult. Now add in what can sometimes take years of paperwork to get clearance from the DEA to study a Schedule I drug like cannabis. And even once you get that Schedule I license from the DEA to study it, who's funding your research? Who's supporting it? There's a decent amount of money from the federal government, from the National Institute on Drug Abuse, a division of the NIH, to fund abuse research into cannabis. That's, of all the cannabis research that's been done, 95, 98, 99% of it's all been around harm, abuse potential, all these things. Okay. Very tiny, because who's funding the medicinal research? Right. That's shifting now, which is very exciting. But that's historically how it's been, half a century. All right, so those are all kind of impediments to this. In addition to the fact that, like, if, for instance, if I want to study LSD, a Schedule I drug, there are several manufacturers of LSD that I can order from. And when it came to cannabis, it was something called the NIDA monopoly. NIDA is the National Institute on Drug Abuse. So they basically, there was only one entity in this whole country that's been allowed to ever federally produce cannabis. Oh, wow. And it's a farm. It's the University of Mississippi. It's a university, and it's a farm at Ole Miss.
Wow. Okay.
And they have a license from the DEA to grow cannabis, and they get funding from NIDA, National Institute on Drug Abuse, to grow this cannabis, to mail it to researchers so they can study its harm and abuse potential.
Interesting.
What are the drawbacks of this monopoly? Well, if I don't like the cannabis that they're growing, or if they have a backlog, or if they're out of stock, or if they're being slow, I have no other options. Yeah. It's a monopoly. Monopolies are bad for competition, business, efficiency, all these things. So, okay, throw in all those variables. It doesn't matter what happens at the state level. The universities are beholden to follow these rules. The only thing that has since changed in terms of everything I talked about is the monopoly, as of literally a few months ago, ended. And there are two other entities in this country that have been issued licenses by the DEA to grow cannabis. But you still have to jump through all the other hoops.
Okay. And the research is still centered around abuse and the negative impact.
I will say things are starting to shift. Okay. There's federal money now flowing towards medicinal usage a little bit. But the states have stepped up and started funding, from the tax revenue, started funding medicinal benefit research, in addition to harm research. Okay. It's important, public health.
Yeah, absolutely.
And then some philanthropists have stepped up too. Actually, my co-founder in Radical Science, Paylene Thorogood, Her foundation's called the Holistic Foundation. They're the largest private philanthropic funders of cannabis research pretty much ever.
Wow. Okay.
Like $5+ million funded. That's how we met years ago.
Okay.
There's not a lot of people handed out money. I was trying to get money, you know. And then to wrap up, how does Radical address all of these? Well, first off, because we don't take federal funding, simply we're not beholden to a lot of these things.
Okay.
So then we go, okay, well, we want to run human studies, clinical trials, the highest standard, gold standard trials. And our rationale is, look, if in 36 states you can walk into a store and buy cannabis, if you're over the age of 18 or 21, depending on what state you're in. And when it comes to other things that are related to cannabis, CBD, CBG, if you can just order that stuff online, we should be allowed to study it, even though its status at the federal level is a little gray, right? We're clearly not breaking the law as badly as someone who's growing and selling a Schedule I drug and selling it to people over the age of 21 and making money and profiting, right? We're just there studying it and, you know, getting data and understanding what's going on. So, and we run all our studies virtually.
Okay.
So no hospitals, no doctors. That's how we get it really cheap, and it gets a lot faster. And so, and we run human clinical trials, and we'll dive into this, I'm sure, throughout the call as well. But there's a few key elements that you want in a rigorous human clinical trial. You generally don't want the people to know if they got product 1 or product 2.
Right. So you have the placebo. Right?
So that's the blinding, and then usually one of them is the placebo arm, because even if I give you anything, you're going to get like a small X percentage improvement.
Yeah.
So if I don't have a placebo arm, I give you anything, and I see the improvement, I go, egads, it worked. No, that was a placebo effect. So what you always do is, here's the placebo group improved this much, your product improved this much. It's real.
Got it.
But if it only improved this much, it's no better than placebo. So these are the studies. Now, our company is only a year old, but we've studied about 10,000 people across about 24 clinical trials, and we're just going at it.
Interesting.
So,
okay, so since so I want to get into the trials and some of the early findings and kind of where you're projecting. But I also want to look at and think about some of the previous research, right, which is what ideally causes concern. And it's interesting to hear that the funding has primarily been around the abuse. So then you would expect the majority of the publications and the majority of the research to focus on the abuse, right?
Right.
And so there's a lot of pushback for, the public health concerns. What are the strongest arguments, right? So I know that there are articles that talk about the impact on youth, memory concerns, the reduction of IQ, specifically for youth, pregnant women, right? And so from a medical perspective, from a research perspective, what is the strongest argument for the potential harm of cannabis to the human body?
And before I dive into that, I think we always have to look, everything has harms.
Absolutely.
Cake has harms. Getting on a bicycle has harms.
Diabetes and
you could fall off a bike and hurt yourself. It's got harms. So cannabis is not harmless by any means, right? I'll preface it with that. And then when you are thinking of cannabis as a medicinal aspect, then a different set of criteria come into play. What's the potential benefit? Does it outweigh the harm? And what's the cost on society? For so long, the US healthcare system has not thought about the economic cost of our treatments. That's why we spend the most out of any country in the world, and we have some of the worst outcomes of every developed country in the world. So now we're starting to think, okay, it's not just did it help you, it's like, did it help you per dollar cost of this drug? If this drug's $1 million, it better damn help you a lot. Right. Versus a drug that's $100 and helps you a good amount. So all those. Okay, so now talking about the harms of cannabis, there are significant ones, but you need to be contextual about them. Okay. The youth is probably a big one that people worry about. And look, the human brain develops all the way until your early to mid 20s. And anything that could affect brain development or tinkers with neurotransmitters, and we'll talk about how cannabis works. Cannabis is tinkering with neurotransmitters. Okay. Could theoretically affect brain development. And from what we've seen from the literature, it probably does detrimentally affect brain development. Now, here's the huge caveat. Lots of things will detrimentally impact youth's brain development. Alcohol can mess with that. Anything that messes with your dopamine system, nicotine, tobacco, other drugs, all of these things, your phones are going to mess with your brain development and devices
Okay.
for kids, right? But we do see that particularly the earlier you use and the heavier you use as an adolescent, there are some pretty significant correlations with, in the long run, what happens to your IQ, what happens to your memory, and things like that. Now, the hard part with any of these studies is that you're looking at observational data and you're looking at association. So there's no placebo blinding control. It'd be pretty weird to like grab a bunch of teens and be like, yo, you're gonna smoke these joints for 10 years, you won't know what's in them. You can't do that. So all we can say is they're correlated. So some people will argue, well, maybe it's teens who already have some genetic or developmental thing, and that's why they tend to gravitate towards cannabis, or they're coping with lots of stress at home, and these things also detrimentally affect IQ. We'll never disentangle it, but it's probably not great for adolescents to use heavy amounts of cannabis. In an ideal world, adolescents use nothing. In the practical world, we know they're out there drinking, smoking weed, all these things. So that's the tricky balance that you have to find. So that's the youth piece. Next up, I would say probably intoxicated driving. Okay. We're worried about. And yes, when you are intoxicated on cannabis, and I should preface this, everything that I just said about youth, and everything I'm about to say about the harms, it's all really linked to THC. Okay. Cannabis has 100 different compounds in there. It seems that THC is the one that's driving all of these things that we're about to talk about. Okay. And so when you're acutely intoxicated on cannabis, you have a roughly doubling of your risk of getting in a car accident. But now again, contrast that with alcohol, which is 4x risk all the way up to 8x, depending on how drunk you are. And so, but what society is struggling with right now is we don't have good ways to detect stoned driving. There's no breathalyzer version yet.
Interesting.
Right. Okay. So someone could be super stoned. Cop could pull them over. Cop's like, hey, I'm pretty, but I can't. It's hard for me to prove it, and I got to go argue in court that it smelled like weed. His eyes were bloodshot. It's hard. So we need that. We need a breathalyzer for cannabis.
So the drug test takes how long?
So they have to bring you in, draw your blood, and then here's what gets even dicier. There's no good data that correlates a certain blood level of THC to impairment. So if the guy is a good lawyer, he'll say, no, yeah, it was in his blood, but he smoked 24 hours ago, and it's like residual amounts, and
got it. Okay.
It gets tricky. Yeah. And then maybe the third bucket that people might worry about the most are certainly pregnancy, and as well as mothers who are still nursing. So THC, because it's fat soluble, it gets really easily into the fetus, it gets really easily into breast milk. So pregnant women, stay away from THC cannabis, and then nursing mothers should probably stay away too. You do see some potential detriments to the fetus and the newborn babies.
Okay, so now we're getting into some of the more scientific nuances of THC and CBD, and obviously you use these terms like
we should back up a little.
Yeah, they're nomenclature for you, but for individuals who perhaps are not as familiar with the distinctions, what is the difference in THC, CBD? Are you able to separate them? If you do, what are the different impacts? Just give us like crash course on the actual science of cannabis.
Totally. So, and maybe even let's zoom out a layer deeper. You guys might hear a lot about cannabis, marijuana, hemp. Like what is going on?
Right.
So cannabis is the scientific term for this plant. Okay. Cannabis sativa. That's the scientific term. It's a species of plant. And then for the last 50 to 100 years, colloquially, it's been called marijuana for various reasons that I'm sure you'll get to in a different lecture. I'm not going to belabor that here. So you'll notice when states legalize, it's always cannabis, because what we've gone back to is the actual scientific name, not the kind of derogatory term that was crafted over the last century. So cannabis. All right. So here's this plant. When you hear the word hemp, you're generally talking about cannabis that is very low in THC. And that's why you can make into clothing, you can eat hemp seed at the grocery store, you can buy CBD from hemp and order it online, and it's not as illegal, right? So hemp got banned with marijuana, but it all came back within the last few years. The US government legalized hemp for textiles, construction, food, all these applications, medicine, cosmetics, all these things. Okay, so cannabis, hemp. The only difference there is hemp has very low THC. So what is THC? So THC is one of over 100 cannabinoids found in cannabis. Cannabinoid just means like cannabis-like. So we discovered cannabis. They're like, oh, cannabis has these things in here, and they're not found anywhere else in the world. Let's call them cannabinoids. They're like related to cannabis, and they're kind of like cannabis. Okay. So THC is a cannabinoid. But there's 100 other cannabinoids, including CBD, which I'm sure almost all of you have heard about now. But you also started to hear things about CBN, CBG. There was an article that came out a few days ago, CBG in human cell studies prevents COVID entry and infection.
I actually saw that article.
Interesting, right?
Yeah.
There's other cannabinoids like THCV, there's a V on the end, that seems to lower blood sugar levels in diabetics in clinical trials.
Wow, okay.
So there's a lot in there. Yeah. And for so long, society and scientists really only knew about THC or cared much about it and blah, 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 blah. Because that's what got you intoxicated. Okay. That's what you could feel instantly. All these other cannabinoids, for the most part, are pretty much not intoxicating. Okay. Okay. So then, now, how do these things work at a high level?
Right. So we know that the THC is the high effect. There's 99 others, right? CBD being the most popular. What is the effect of the CBD? Right. If you were to take it outside of the THC?
Yeah. And so here's another tricky thing is for so long, we have studied cannabis as a plant material. But again, this was one type of cannabis grown on this farm in Mississippi. Okay. And so we say, oh, all cannabis will tend to do this. Well, again, cannabis is hundreds of compounds. So this is where it gets a little tricky. There are certain studies that have been done with pure synthetic THC. In fact, that's been FDA approved since the 1980s to treat cancer patients who are nauseous and to treat HIV/AIDS patients who are losing too much weight. Synthetic pure pharmaceutical THC. FDA approved since the 1980s. Yet cannabis sits as Schedule 1. And then we have studies on CBD. And from what we can, not a lot of human studies, lots and lots of animal studies. Okay. But just talking about human studies, it looks like CBD has potential to benefit schizophrenia, psychosis and schizophrenia. It looks like CBD actually has anti-addictive properties. Lowering cravings for people who are addicted to things like opioids specifically, has anti-anxiety properties. And what has been most studied is its anti-epileptic properties. In fact, CBD is FDA approved for that in a pharmaceutical pure version. And in terms of how these things act upon the human body, just like, we're like, hey, here's the cannabis plant. Oh, there's stuff in there. Let's call them cannabinoids. Well, about 25, 30 years ago, we were looking around in the human body, and we basically found something that we found the thing that THC binded to in the brain. Okay. And we're like, okay, well, if THC is a cannabinoid, we'll call that the cannabinoid receptor. It sits in our brain and it receives the THC, that receives the cannabinoid. And then we're like, well, why does this exist? It's probably because our bodies make something naturally that also goes in there. Yeah. So they started hunting around and they found it. And what do they name it? Endocannabinoid. Internal cannabinoid.
Interesting. Okay.
So THC works by basically mimicking your body's own endocannabinoid. Your body doesn't know the difference.
So everyone's body naturally produces cannabinoids or something similar.
Yeah, and not just every human, every dog, every cat, every reptile, every fish, every bird. It's a system that evolved hundreds of millions of years ago and is preserved throughout all that lineage. So it's a fundamental part of higher order multicellular life and physiology. There's a good chance all of this is just pure randomness. Okay. Like the cannabis plant just happens to make this stuff, and then a human being walked by and was like, whoa, like what is this? It's also possible that it evolved over time, either as a, here's the thing, I don't know no one has the answer. Did it evolve these compounds as defense mechanisms or as attractants? So as a defense mechanism, you can see like if you nibble on it and like you feel a little funky, you might not do it again.
Interesting.
Right? Just like how like mushrooms are, some of them, they're psychedelic to get you to not like eat them.
Yeah.
And you trip out. Or are these attractants? Like because you eat them and it actually is good for you, and like that deer is able to like do better, and then over time they develop. Now what's weird is like you don't see tons of animals in the natural world that eat cannabis. There are some, but you don't see tons of animals that eat it, so we don't really know.
Okay,
but
so there's no nutritional benefit to it.
Well, the hemp seed is super nutritious. Hemp seed is cannabis seed.
Okay.
It's marijuana seed.
Okay.
And it's highly, highly nutritious.
So the seed is nutritious.
The seed's very nutritious. The plant itself doesn't have much nutrition. Yeah.
Okay. Interesting.
Yeah.
So now, in terms of the endocannabinoid system that interacts with the cannabinoid plant, right? And that process, you said, if it happens too early, could be harmful. But once an individual has matured, over 20, once the brain has stopped developing, are there continued harms, or is it then simply the reduction in, appetite, or reduction in addictiveness of certain, other products, or the high effect, and then does it just kind of go away and you kind of you level back to zero?
Yeah,
right?
It's a great question. And again, zooming in on really just when we talk about the harms of cannabis, I generally zoom in on THC.
Okay.
Real quick caveat, CBD has some potential harms and side effects. For instance, people that use them sometimes can get tired and have diarrhea.
Okay.
And if you already have some sort of liver disease, it looks like CBD might actually potentially worsen that liver disease.
Okay.
But outside of that, CBD is pretty darn safe.
Okay.
So just then zoom back out now. When we're talking about the harms of cannabis, again, it's usually really coming down to THC. So yes, the adolescent thing is the most concerning. When it comes to the developed brain, you don't really hear tons of people in the public health sector saying, we got to prevent, because we're doing all sorts of weird shit to our brain with alcohol and devices and all that.
Yeah.
There is a concern amongst the elderly who are already at a risk for falling, who are already maybe their cognitive reserve is already diminished a little, that if they're like just acutely stoned and intoxicated, maybe they're higher risk for falls, maybe it's harder for them to make judgments and whatnot. But there hasn't been too much research into, because again, this stuff hasn't been this widely used and accessible ever like this. But for the most part, again, the concerns are really falling down to adolescents, pregnant women, driving. One last thing I forgot to mention, which is important, is the potential for it to precipitate schizophrenia in people who have a genetic predisposition.
Okay.
So generally, I always say if you have a family history of psychosis or schizophrenia,
stay away.
It's probably you have a genetic predisposition. Stay away from THC, and especially when you're an adolescent, that seems to trigger it even worse.
Okay. Wow. Interesting.
Yeah.
Okay, so now let's get to a little bit of the research.
Yeah.
The fun part, probably for you. So I want to hear first. You were at UCLA. You were doing research there, which was obviously barred a lot. But I guess I'm concerned about the academic research and what that looked like, what you were able to accomplish. And then if you could just kind of transition into your current work.
Sure.
And how you've been able to build upon what you started at UCLA.
Sure. So, and again, at first start with some just to give you guys a sense of the context. In general, when we talk about non-pharmaceutical compounds, oftentimes the data, most of the data sits with cell and animal studies. That's because they're cheap, they're easy to do, you don't have to deal with human beings, It's a lot easier to get approval, all these things, right? And so when we talk about cannabinoids, there's some pretty fascinating, and even just THC specifically or CBD, there's some fascinating things they do in cell or animal studies. And before I tell you those fascinating things, I want to preface it with that a lot of times what works in a cell, what works in an animal, does not work in a human.
Right.
And that's because I'll give you an example. On a cell, I could drip cannabinoids and have the concentration sitting around the cell be super high. But for you to deliver cannabinoids at that concentration through my body, you'd have to give me so much, and I have to absorb a bunch, and it's right. So organ systems, organisms, very different playing field. But at the cell and animal studies, man, we see that these things are anti-inflammatories. And inflammation, we're finding out, is a root cause of almost every chronic disease, heart disease, Alzheimer's, diabetes, MS. We also see these things have antioxidant properties. We see these things have neuroprotective properties, being able to preserve and prevent damage to brain tissue that's under stress. We see these things have anti-cancer effects, anti-tumor effects, sometimes slowing the growth of cancer cells, sometimes actively killing cancer cells.
Oh, wow. Okay.
Again, so those are some of the, none of this has been really studied in humans, so everything massive grain of salt.
Okay.
So when you say like, cannabis cures cancer, and you see those blog posts, no.
Yeah.
And a couple rats, it shrank tumors and stuff, So that, but it's fascinating stuff. And fun fact, Google U.S. government patent on THC, and you'll find that the U.S. government actually patented the antioxidant and neuroprotective effects of THC and other cannabinoids like 15 years ago.
Oh, wow.
Yeah.
In spite of it having...
The whole thing's so wonky. The whole thing's so wonky. So that's what we know at the animal level. And then at the human level, and this is where it starts dovetailing with some of the stuff we were doing at UCLA, one clear area where we actually have a lot of human data on the effects. And again, this is where I have to start breaking apart THC versus CBD. So let's talk about THC and or THC-rich cannabis that doesn't really have that much else other stuff.
Okay.
Chronic pain is clearly an area where whether you're inhaling cannabis, taking THC, it's all been shown that it can actually help chronic pain.
Okay.
And the reason this is important is we don't have tons of great solutions for chronic pain. And as we're finding out now, when you give someone opioids for chronic pain, you're creating addiction, opioid epidemic, overdose deaths, inflammation in the brain, all these things. So I think it can be a very powerful tool. And there's public health epidemiologic data that as states legalize cannabis, medically, they tend to see decreases in opioid overdoses.
Okay.
Again, associations, you can't prove causation, but it's interesting. We talked about the indications, and that was some of the work that we had started at UCLA, was looking at chronic pain, understanding it much better, understanding it at different dosages, what it is actually, the types of chronic pain as well. Some other areas that THC...
And is this, sorry to interrupt, is this addictive? Because you didn't name that as a potential harm.
Oh my goodness, you're so right.
When we talk about the, pain relief, right? Most pain relievers are addictive.
I back up, and that was the fifth item that I wanted to get to. So cannabis is addictive.
Okay.
And anyone says it's not is not correct.
Okay.
Now, let's talk about context. It appears to be much less addictive than nicotine or opioids or alcohol.
Okay.
But it is addictive.
Okay.
So that is another concern as well. You develop a dependency to it. You can have withdrawal from cannabis. It is not that common. But if you smoke cannabis pretty regularly or use cannabis regularly and you stop, you can go into withdrawal. And it can be you're not sleeping well, you're irritable, you have no energy. And when we deny that it exists, it's hard because someone might be trying to get help, or every time they quit, they feel like crap, so they go back to smoking it. And if no one recognizes that as withdrawal, it's also hard to get them the proper help they need and all these things. Yeah. But again, the physical dependency is not that common.
Okay.
But yes, cannabis is addictive. So for instance, but at least as far as chronic pain goes, what we don't see is necessarily a buildup of tolerance where you need to use.
Okay.
You can build up tolerance to the intoxicating effects of cannabis, but at least in the chronic pain literature, it seems that you don't build up a significant tolerance and need more and more cannabis to get the same pain relieving effect.
And is it possible to take the TCH, get the pain relieving effects without the high?
So I love that you brought that up actually. The data actually shows lower doses of THC and less potent cannabis that has less THC actually might be more effective for pain than higher doses.
Okay, interesting.
And this dovetails into another area, which is the potential for cannabis to maybe impact sleep in a positive way. You also find that there's only been a couple human studies done, but low levels of THC seem to be beneficial for sleep, or seem to work better for reducing sleep than higher doses of THC. So more is not necessarily better.
Interesting.
You know.
Okay. Now it sounds like, and I know I read a little bit of your vision for cannabis, and I think it was something to the effect of just kind of like revolutionizing, the medical industry, where like, to transition to more plant-based, herbs and something more sounded like more Eastern influence.
Sure.
And so I wonder, is this a threat to the pharmaceutical industry? And do you think that some of the pushback is because we have such a multi-billion-dollar industry of pharmaceuticals that really are aimed at, and I know you mentioned earlier some of your concerns with the healthcare industry, right? But we know that most medicines are aimed at just kind of like keeping the patient ill, but maintaining them as opposed to
Sure.
curing the actual illness, because then that dries up all of the funding, right?
Right.
And so I'm wondering, when you're doing this research, is that part of the motivation? Do you see this as kind of being a transition of the ways in which we think about medicine?
Sure.
By moving towards cannabis?
So there's a couple interesting observations that I've made over the years. I mean, the first thing is, and you guys might have heard this statistic, a majority of FDA-approved medications to date were first discovered in plants.
Right.
But you can't patent and own naturally occurring compounds or plants. So what you do is you create a copy that looks almost the same, but it's a slightly subtly different, and then you patent that and take that through clinical trials. Now, pharma has done amazing things for humanity. Antibiotics and oh my goodness. Mm-hmm. So it's not that, I think there needs to be, if there were perfect information, we would know in what instances it makes sense to use this pharma drug because it's clearly superior.
Yeah.
Better effects, less side effects. And in this situation, this supplement or this food nutrition intervention, better outcomes, less side effects.
Yeah.
But the way that clinical research is done, the way that it's funded, all that knowledge really flows into pharmaceuticals. So the doctor isn't to blame when he's like, I don't know anything. I can't tell you whether or not to use ashwagandha or turmeric.
Yeah.
I haven't seen large-scale phase 3 blinded clinical trials, but I have that on this medicine that I can prescribe for you, and I can trust that. So I think that there should just be a level playing field. And there might be instances where using both a pharma drug and an herb are better than either one in isolation. And again, the main three variables are benefits, risk, cost. So those are the ones that you're constantly having to look at in terms of when does it, when might it work, which one to choose.
Okay. And so in terms of the research that you're doing now with Radical, okay, so what are you finding that you can disclose,
Sure.
given whatever NDAs that you may have signed?
Sure.
What can you disclose that you're finding, and where do you see the future of cannabis and as a medicinal use? Are you excited about the research that's coming in the first year?
Sure. So our company's a little over a year old.
Okay.
So a year ago, we were an idea on paper. We're now close to 20 employees, and we're going at it, we will have much more information to share even in the next 60 days. There's a massive data set right now that our data scientists are going through to be able to give even more interesting observations or findings to the public. But in general, so far we've been focused on studying non-THC cannabinoids, because those are really things we know nothing about.
Right.
Even CBD is being used by 20% of the US population. There's never been a CBD insomnia clinical trial. There's never been a CBD pain clinical trial, all these things. Yeah. So we picked kind of these minor cannabinoids to start with. And so, again, more information will be coming soon, but some things that we're clearly seeing are that the products matter a lot. So it's not just, hey, I'm taking a CBD product, it will work for me. No. So what was the dosage? What's the form factor?
Okay.
So the thing is, CBD doesn't actually absorb into your body that well. we could say it has low bioavailability. Same goes for THC.
Okay.
So if I just put pure crystalline CBD in a pill and you eat it, you're not absorbing very much. But if I formulate it a certain way, if I deliver it a certain way, I can improve the absorption sometimes by 5x, 10x. So, and that makes a difference in the outcomes as far as we're seeing.
Okay.
And so, a lot of people ask me, I just walked into the store and bought the CBD product. I'm like, you need to be much more discerning than that. We're also finding that there appears to be differences in certain demographic or behavioral characteristics. And this is where we're trying to tease it apart further.
Okay.
But there seems to be some early signal that different ethnicities respond differently to, in this case, CBD.
Interesting.
And it could be just a genetic thing, right? So those are some of the things that we're starting to tease apart. Our studies have been focused on pain, sleep, and anxiety and quality of life.
Okay.
And there's a bunch of studies underway right now looking at CBN and CBC. These are other minor cannabinoids. And we're about to start a series of studies looking at THCV to see if it can actually improve energy and focus, almost like caffeine. Anecdotally, a lot of people seem to think so, and we kind of want to put it to the test.
Okay. So you mentioned a couple of things that we haven't really touched on, which is, ways of which you can consume.
Right.
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 Because we didn't even really get into that, but you can digest it, right? You can eat it. It can be put in drinks. There's gummies. There's drops. There's smoking, right? Which people think about. Typically, when you think about marijuana, you think about smoking it. But then there's so many other ways. When it comes to the medicinal use, is there a preferred way, or is there?
Yeah.
I mean, it's kind of odd to think about, some elderly person, smoking a joint because the arthritis, right? Or
Sure.
Whatever the case
Sure.
may be. What are some of the preferred ways, or what are some of the
Okay.
studies showing in that area?
So, fun fact, for about 10, 15 years, the federal government actually supplied a few dozen U.S. patients with tins of their cannabis cigarettes from the farm in Mississippi so that they could use it medically.
Okay.
It's because these patients sued in court and won. Or not, they didn't win, but at that point the DA was like, you know what, you can, for these couple dozen people who are like terminally ill, we'll send you this cannabis. So it was government supplied. Interesting. And they were smoking these joints. A lot of the research on cannabis has actually been done with either smoked joints or vaporized cannabis, showing benefits for things like pain and all these other things. So that's interesting. Intuitively, you're right. Smoking, it's probably not the best way to consume it.
Right.
But here's what's interesting. Notice I didn't say like lung cancer in terms of the harms of cannabis.
Right.
It's because all the epidemiologic studies have shown long-term heavy smokers of cannabis don't seem to be at increased risk for lung cancer. They don't even seem to be at increased risk for emphysema or COPD, which is that cigarette smokers definitely have. Basically, the lining of your lungs die.
Yeah.
Right, and you get like the.
But no bronchitis or.
What you do get is a little definitely increased risk of like phlegm and stuff like that. But nothing that's like permanent or serious or life-threatening.
Okay.
Like COPD, emphysema, lung cancer.
Interesting.
So for that reason, like I think our knee-jerk reaction when we hear smoking is we think cigarettes.
Yeah.
Tobacco.
Nicotine.
Oh my God.
Right.
They wreaked havoc on your lungs. And then you look at the data for cannabis and you're like, oh, well, okay. What are the potential benefits of, I'm not going to use the word smoking, but inhalation of, say, THC? Very quick onset. Right? Very predictable. The other thing about THC is depending on if you're on an empty stomach, if you just had a meal, it could hit you in 30 minutes, it could hit you in 2 hours when you take it orally.
Yeah.
Because it's got to go through your stomach, to your intestine, to your liver. Your liver tinkers with it, then dumps it into your bloodstream. So when you smoke it, it goes lung, bloodstream, boom. And so it's very predictable. So for some folks, maybe that's an easier way for them to dose, or maybe they have a condition where the onset's relatively sudden. Like, again, anecdotally, there's a lot of anecdotal data and observational data that can help with migraine. So if you feel like a migraine attack coming on, maybe you want to grab a joint and smoke it. I'm just painting both sides of the story. So that's a smoke. But, the most classical way to think of it is probably going to be through oral ingestion. In a capsule, edible, gummy, whatever. But a capsule is what, again, medically we think about as the most easy way to do it. But we do need to figure out the bioavailability issue. How do we get the bioavailability up? And how do we make the absorption more predictable? So every time it hits me in 30 minutes and it hits me with the same effect, and I get medical benefit with minimal intoxication. And that's what studies have shown, that you can get medical effect with minimal, sometimes barely any intoxication. Sometimes lower doses are actually better for things like pain and sleep. And then there are other form factors, topicals.
Okay.
There's really virtually no data on topicals.
Okay. And then what is a topical?
Oh, sorry, skin stuff.
Okay.
So, and people use it for like arthritis or muscle pain or stuff like that.
Okay.
Frankly, I don't, sometimes I wonder if it's even penetrating the skin much. Mm-hmm. But this is where formulation matters. If it's formulated right, it'll penetrate the skin. It'll get to, say, the muscle and tissue below, and theoretically it could have pain relieving effects there. Wow. Never really been shown yet in human studies.
Interesting. But
there's a whole cottage industry popped up. But speaking of skin, we talked about anti-inflammatory, right? And also cannabinoids have antimicrobial effects, anti-sebum effects. Sebum's the stuff that you get from acne.
Okay.
So there's a lot of interest in using cannabinoids to treat like acne and stuff like that.
Wow.
So even if it doesn't penetrate the skin, it just stays in the skin, there might be theoretical benefits. If you have eczema or irritation, any sort of dermatitis, psoriasis, things like that, you could rub it on. Then, and lastly, there are folks who are using cannabinoids via suppositories.
Okay.
There's some people using rectal suppositories, but vaginal suppositories are they're small, but they're a growing section of the form factors.
Okay.
Yeah, and again, fully now, the vaginal canal is abundant in cannabinoid receptors, and anecdotally, women report that sometimes it can help with menstrual cramps. Sometimes it can help with different pelvic pain syndromes that they might have related to having like fibroids or certain gynecologic disorders and pelvic pain syndromes. So again, when we talk about does cannabis work, it's like, what compounds in cannabis are you talking about?
Yeah.
At what dosage, in what form factor, and then for what specific conditions. Yeah. So the plot thickens a lot.
Wow. So that sounds like a lot of future research.
A lot of work.
Yeah.
And you'll never figure this out when a clinical trial costs millions and takes years.
Yeah.
And so that's why we've worked really hard to like literally take a 10x improvement, 10x cheaper and faster, run these studies, and that's the only way that you'll remotely get a shot at having some predictive ability to say, okay, here's a person, here's the effect that they want, here's the type of product they should look for, here's the type of dosage, et cetera, et cetera.
Right. So this is a little off subject, but definitely within your wheelhouse. Are you doing any work, or what is your thoughts on potential rescheduling, right? Because I know from a research perspective, it's super important, right?
Yep.
If that schedule is moved to a Schedule 2 or a Schedule 3, or if it's removed completely, right? It just opens up so many more doors, because not only then are you able to get private funding, but then you yourself can apply for federal funding, and it just allows so much more work to be done. What are your thoughts on that, just being situated in that space?
So, if it moves to, say, Schedule 2, you still would need to go get a license for it, but it's an easier process, and it's less restrictive. Theoretically, you could apply for more funding, and or the NIH might create more funding pools specifically for that. And you mentioned, cocaine is a Schedule 2 drug, because cocaine can be used as an anesthetic.
Interesting.
Right? It relieves pain. That's why dentists at one point were using cocaine for an anesthetic.
I was wondering why it was a Schedule 2, actually.
Otolaryngologists, ear, nose, throat doctors will use cocaine as an anesthetic when they're doing like nose procedures and stuff.
Interesting.
So theoretically, it could improve. I don't think it would be dramatic, actually, unless it's like completely descheduled. If it just goes from Schedule 1 to Schedule 2, it might be a little easier to get a license to study it. Maybe there's a little more funding, but it still doesn't dramatically change things. If it goes off schedule, then things become, you don't no longer need a safe and cameras and security systems and paperwork and all this stuff.
And you can go to the bank.
Oh yes,
That's
yeah. Oh, that's a whole. Oh well, actually yes. So I just talked about as a researcher the implications. Oh my God, if it gets descheduled, then yes, the operators can bank. They could cross state lines. So much more stuff, right? But yeah, from just strictly and if it becomes completely descheduled, doctors can prescribe it a lot easier as well. If it goes to so what's happening on that front? I think we're still a few years away from it. I think what's going to happen first is banking reform. The Safe Banking Act is something really interesting to keep an eye on. It could pass this year. And that'll be big because what will happen is banks can then serve businesses, and banks are insanely federally regulated entities. So then all the other companies who've been very skittish about cannabis and working with cannabis companies are like, well, if you're basically funneling their cash, maybe I'll let you, maybe if I'm some tech company, I'll let you use my app. And before I wouldn't let you. Or maybe if I'm Google, I'll let you advertise on my platform now because the banks are now processing your money, your drug money, and the feds are cool with it. Like, all right, my risk level has changed. So I think banking reform will come first, and then some sort of sweeping federal reform. I think we're still a few years away, unfortunately. And it's not because both sides of the aisle don't want it. I think both want it. I think they're using cannabis as a bargaining chip. Some people are just focused on like, let's get more tax revenue to all the states and all these things and get the tax revenue out of the illicit market, put it back into cities and states. Other people are like, great, but we don't want to do that till you change till we figure out a way to have criminal justice reform for all the people who've been jailed for cannabis and other related nonviolent drug offenses. We want to make sure this tax revenue isn't just going back to cities and states. It needs to go to areas that have been disproportionately policed or affected by the war on drugs. And so I think the agreement is going to be not just like, I think at this point most people are like, yeah, it should be legal, but it's how do we get maximize the benefit and or maximize what our constituents want if I'm a lawmaker.
Okay. Well, listen, I appreciate you taking your time
to
share with me. I learned a lot. Hopefully the viewers learned a lot. And I'm looking forward to just future research. And I mean, given what I've heard from you, I'm excited about hearing about the cannabinoids and the future benefits, ideally, that will come from your research. But then just also the future of medicine. I think it's promising, and I'm looking forward to hearing more.
There you go. Well, thank you for having me, Dr. Gray.
Thanks a lot.